I'm Benedict Benigno. I am a gynecologic oncologist in Atlanta, Georgia, and I'm the founder and CEO of the Ovarian Cancer Institute. The patient I've been asked to discuss is 58 years old and in her usual state of good health until she discovered that her abdomen was distending and she had some cramping abdominal pain. And this is unfortunately the way most of these patients with ovarian cancer present. She had a CT scan which showed a 4 centimeter adnexal mass. She underwent an operative procedure. Ovarian cancer was found. There was a papillary serous adenocarcinoma. And she was debulked, which means that all of the tumor that is even outside of the pelvis is removed. And unfortunately, there was residual disease down to 1.5 centimeters. She was treated postoperatively with intravenous chemotherapy, with cytotoxic chemotherapy, with carboplatin and paclitaxel and bevacizumab or Avastin. She had 6 cycles and the chemotherapy was stopped. And then she developed symptoms of cramping abdominal pain exactly the way she presented originally. She had an elevated CA-125. A diagnosis of a recurrent cancer was made, and she was treated with carboplatin, paclitaxel, and bevacizumab again. And then about 18 months later, she had yet another recurrence and was treated once again with carboplatin and paclitaxel and bevacizumab. Unfortunately, her course is the way it almost always is. Depending upon whom you read, the recurrence rate is 70 to 80%. So we expect the patient to develop a recurrence. She was BRCA negative, but she was also HRD positive. And I'll get back to that particular aspect in just a moment. But the reason that the diagnosis is almost always made in an advanced stage is that the ovary is the only organ in the body that has its functioning cells facing the interior of the abdomen. So long before a tumor forms in the ovary, cells flit off and implant on all peritoneal surfaces, and they favor the surface of the small bowel. And so the patient presents, for all practical purposes, with an intermittent partial small bowel obstruction. Almost everybody is given intravenous carboplatin and paclitaxel. This has been going on for well over 30 years. Very, very disgraceful, nothing new in over 30 years. The operation changes in intensity, the dosages and the interval between infusions may change, but the carboplatin and paclitaxel has remained distressingly stable throughout most of my career. I give carboplatin at an AUC of 6 and also Taxol in a dose of 175 milligrams per meter square intravenously every 3 weeks. Both drugs are given every 3 weeks. Sometimes people choose to give the paclitaxel every week. In that case, the dose is lowered. 2 years is right around the time that you would expect a recurrence, 1 to 2 years. The later the recurrence following the cessation of chemotherapy, the better the prognosis is.